As Lydia said, I'm Simone Kelly. I'm the Nurse Unit Manager for Radius at Sutherland Hospital. We're a rapid assessment unit for general medicine patients, and I just wanted to take a couple of minutes to remind you that we are open and accepting referrals directly from GPs, straight through to our staff specialists for conditions such as dizziness, back pain, cellulitis, hypertension, joint pain, UTIs, and falls. We're happy to see patients as soon as you call through to our doctor, and we are open throughout COVID. So we would love to get your referrals and bring patients directly through to us as a way to avoid ED. And hopefully assessment units are open from 9:30 till 6, Monday to Friday. And yeah, happy to have any conversations or take any phone calls, even if it's just to discuss a patient that you're not certain about. We'd love to receive your calls. So thank you very much.
Thank you, Simone. Thank you very much. And now I would like to introduce our facilitator for tonight, local Sutherland Shire GP, Dr. Janine Hopkins. Thank you, Janine.
Thanks, Lydia. I just want to introduce our speaker tonight, Dr. Peter Grant. Dr. Grant's the Deputy Director of Emergency Medicine at St George Hospital. He's worked there as a staff specialist for the last 25 years. And he's also been visiting specialists at the emergency departments of Calvary Healthcare Hospitals in Canberra since 2003. Additionally, Dr. Grant's had a lot of experience in aeromedical retrievals across the state and worked for this service part-time for 4 years. And he's also on the board for State Medical Assistance, which is a paramedic and patient transport organisation. He's also an active member in our Medicare local and primary health network steering committees and has an interest in promoting good relationships with the general practice community. And his other interests include interactive medical education and current projects aiming to improve patient flow and implementing innovative models of care. Interestingly, prior to completing his medical degree, he undertook a Bachelor of Science and did an honours year studying exercise physiology, and has even worked as a personal trainer and gym instructor. So to the great benefit of emergency medicine, we're very grateful that he was persuaded to pursue a different career path to these. And with his wealth of ED experience, and particularly in the light of how busy emergency departments are at the moment, we're very grateful that he's agreed to come along tonight and speak to us and give us an update on some emergency medicine topics. So welcome, Dr. Grant.
Thanks very much for that kind introduction, Janine. I'll just pull up my talk. There we go. And thanks to everybody who's joining us online. I'm sorry we can't do this in person. Now, I was going to cover tonight emergency medicine applicable to general practice, and then run through most of the doctor's bags medications and discuss on the way conditions that those medications might be useful. I realise 90 minutes is a long time on Zoom, so I've got lots of colour and pictures, and it's quite a long talk, and I'll keep an eye on the clock and we'll skip ahead if we need to. I'll just go next. Just a short disclaimer. I mean, as far as I know, everything in this talk is up to date and current and well researched. You know, medicine changes very quickly, and what's correct today mightn't be next week. So please don't take this as a definitive text, and always think about other guidelines. And just to start off, there's a lovely picture from the other day, sunset, with the Toll helicopter on the helipad of our newish building. So I'm going to do a very, very brief outline of ED. And at this time of year, these times, you can't have any talk on ED without a COVID update. So I'll run through the doctor's medication bag. I was asked to talk about some specific topics, as I've listed there: anaphylaxis and croup and pediatric seizures. And along the way, we'll discuss who to send and not to send to EDs, and we'll leave some time for questions at the end. Okay, so just at George ED, they're funny times, because when COVID started, our numbers went down, and then our numbers went up again. June just passed, it's been our busiest June ever. Monday evening has become the busiest shift of the week. And I can speak for Sutherland as well. We're getting random days of incredibly high presentations. The 14th of June was our second busiest day ever. And that's despite having no flu and no particular theme to all those presentations. Our activity still peaks twice a day, usually once around 11 and once around 9. And at those times, we often get 25 and 30 presentations an hour. Waiting times tend to blow out a little bit. And as you've probably seen in the media, access block is a terrible challenge for all EDs at the moment. And in the COVID era, the days of coming to work with a sniffle are over, so sick leave has gone up. I think I may have showed this graph previously, but this is rivals by hour. I don't know if you can see the cursor, but there's a peak at about 11 and there's another peak at about 8 or 9. And this graph pertains to the 20 to 45-year-olds, which are one of our boom demographics. And they tend to come in at typically 8 p.m. Once a year with conditions that don't require admission and probably don't really require ED. And if you come in at 8 p.m. and the waiting time's 90 minutes and have some basic tests, those patients often wash over into the night shift. And we've broken those down. Interestingly, more than 50% in that age group don't identify as having a GP, yet nearly all teenagers and paediatric patients do. So if there's a way for your teenage patients to keep them in touch with your practice and if they have a GP as adults, I'm sure that would be better for them and certainly better for us. So COVID update. So COVID's really taken over our lives at the moment. During a lockdown like we have at present, the lower triage categories go down quite a lot, but the higher triage category patients are unchanged in number, and they seem to be more acute and more complex. And we've had days of over 100 admissions in 24 hours, which is a huge number. Now, whether people are waiting longer and coming in sicker, we're not sure. As I mentioned, we're breaking records sometimes with any particular theme. And we're getting lots of out-of-area patients. There are GPs from Western Sydney today as far away as Liverpool now sending patients to St George with the perception that we've got less COVID and it's a safer place to come. The one visitor policy during COVID, which is now a no visitor policy, makes it terribly hard to look after the elderly and the cognitively impaired, and especially if there's a language barrier as well. For those non-specific presentations like dizziness and weakness and lightheadedness especially, to tease that out over the telephone or with an interpreter is very difficult. And it's very hard for some of those patients are just bewildered when they're in ED and there's noise and movement and there's no relative at the bedside. So it's very, very hard on them. And it's amazing how many cognitive steps the COVID era adds. There's pre-triage and pre-screening and deciding whether the patient's hot or warm or cold, whether they need one of our 2 negative pressure rooms, single room, general bed, waiting room, and very hard to fast track. I would normally intercept every new patient as they arrive and maybe listen to their chest or poke their tummy. But now it involves a set of PPE, which is very wasteful. We were saying earlier to Janine, we go through about 7,000 masks a week in ED, and the hospital has a stock of about 2 million. So the turnover of PPE is quite enormous. This wave of COVID, we actually had ample supplies of PPE. Last year, we actually had to ration. Other things, imaging is batched, so you try to put the warm patients together, which slows things down. And I never realised I started wearing a mask how much many elderly patients who are hard of hearing rely on lip reading. So Delta strain, so it is really, as you've seen on TV, it's a different beast to the B117 strain, I think it is, that we had last year. And as Gladys and Kerry tell us each day, it's a household rather than individual disease. I remember last year there was a family of 5. I saw one patient with florid symptoms, and the other 4 just never contracted the COVID, just by following simple precautions. Whereas now it just goes through the whole household. As you probably know, infectivity seems to precede the symptoms to a greater degree, so patients are infectious before they have any symptoms. And remarkably, children are spared serious disease. And I have it on good authority that since COVID started, there's not been one single child in New South Wales admitted with a COVID illness. Some of them have been admitted for logistical reasons or for other illnesses, but not one. How much the kids are the super spreaders, we don't really know. And so PPE, so if I'm seeing a hot patient, that's the full regalia of PPE, especially as an aerosol generating procedure. So they'll come to the mask and the face shields are great for stopping droplets, but if you want to stop aerosol and COVID landing in your hair and on your neck and getting onto other parts of you, you need a face shield, a balaclava, a mask, gloves, a high-grade gown, covering for your boots, and then another waterproof gown on top. It's very hot. It's very hard to do fiddly work. It's bad when your glasses fog up. And I guess putting all these layers on is one thing, but doffing, taking them off, you have to follow very strict procedures and protocols. So you're not slapping a contaminated sleeve across your face or across someone else's face. So it takes quite a while to get that gear all on and off appropriately and safely. So I know we see lots of people around in surgical masks, which are great for stopping droplets. The N95 mask, as pictured there, protects against both aerosol and drops. It emits particles only smaller than 0.3 microns. Coronavirus is about 0.1 microns, but it's always going to be attached to a droplet or fluid or something. So it's a very effective barrier. There's all sorts of different brands which seal different shapes of faces better than others. And if you look at the picture down the bottom, there's something called fit testing, where they look at the gas flows in and around the mask while you're talking, moving your head, bending over, and find a mask that's just right for you. So this one pictured is the one that's right for me. It looks soft and cuddly to feel, but it's really tight and really uncomfortable. And you can actually get a pressure area on the bridge of your nose if you wear it for too long without a break. But if you're serious about stopping droplets, certainly need one of those masks. Droplets are happy to invade the mucosa of the eye as well, so you need some sort of face shield. The bottom right-hand corner is the sort of goggles we tend to use, added to a face shield for a high-risk patient. There's some quite trendy ones that the young'uns tend to have as well. So those two things are between them excellent protection against droplets and aerosol if you don't have a gown and gloves to supplement them. So what things generate aerosols? Well, unfortunately, CPR aerosolizes our COVID, so does bag valve mask ventilation, to the point where if we're intubating a likely COVID patient, we actually avoid bag valve mask. Non-invasive ventilation, so CPAP and BiPAP. And what we would often do is try to jolly the patient along for an hour, which is how long it takes to get a rapid test. But if they really need it, we could go straight into non-invasive ventilation and take adequate precautions. Obviously, intubation, even high-flow oxygen and nebulizers, and even things like nitrous oxide and putting in a nasogastric tube or taking a foreign body out of the nose. So there's lots of things where we might be exposed to aerosolized virus. Sorry. The big thing I've noticed about Delta strain is the extraordinary hypoxia that patients have and how bad their X-ray looks, which, and you look at the patient, you look at those observations and X-ray, it's hard to believe it's the same person. So I put some observations here. This is a 40-something-year-old patient who's day 6 of his COVID illness. And if you can see on the right-hand side there, he comes in the door with oximetry of 30%. Which would normally have someone unconscious, but he's got a GCS of 15. His oxygenation comes up to 78% on some high flow, but his work of breathing just doesn't look too bad, but his X-ray looks terrible. So I'll just to compare this to flu, this is a terrible case of influenza B with terrible viral pneumonitis, and if we compare that to that person, so not dissimilar, but dreadful looking X-ray. But in fact, the progress, the influenza patient on the left was day 2 of their illness, their oximetry is okay, they're in extremis, semi-conscious, they need to be intubated immediately. The guy on the right, with probably a worse, if anything, X-ray, is wide awake, has a few hours of non-invasive ventilation, and he can be intubated semi-electively. So it's a case of almost ignore the oxygen saturation and treat the patient in Delta strain. The X-ray stays abnormal often for some time after the resolution of the acute illness. So this is an example of post-inflammatory change at about 3 weeks. So you may find patients coming to your practice with some ongoing respiratory symptoms, and you might see an awful looking X-ray that looks like that, even though the patient's relatively well. And if I just mention a bit about venous thromboembolism, I know we're told by Gladys and Kerry that people should go and talk to their GP or now their pharmacist to discuss the pros and cons of AstraZeneca, if that's the only vaccine they have available. And we know that the risk for venous thromboembolism in AstraZeneca is very low, and that compared to the disease itself. But here are some quite recent figures from Lancet Haematology, so hot off the presses in July. So patients who are hospitalised with COVID, even with DVT prophylaxis, have about a 14% incidence of venous thromboembolism, raising to nearly 50% if you go to ICU. So huge, that's even with prophylactic Clexane. And the theories are it's a multifactorial thing. There's injured endothelium that's likely to clot. There's more elevated prothrombotic factors, maybe a cytokine storm activating the coagulation cascade. But the other point is we don't know how long that abnormal clotting lasts for. And patients who recover from COVID, 25% still have an elevated D-dimer at 4 months. So there maybe even is a protracted tendency to clot. So you can certainly tell your patients that if they don't want to die of venous thromboembolism, they're much better off having an AstraZeneca shot than chancing their arm with catching COVID. So here's just a CT, one cross-section showing the COVID inflammatory change. So all these fluffy areas at the posterior of the lung bases. And this guy's here, day 28, yep. And just where that circle is, PEs galore. So that often the two conditions coexist if you needed any convincing. Okay, so moving on. You may have heard of RPA Virtual, which is a telehealth service offered by RPA Hospital that monitors a huge number of patients at home or in hotel accommodation, which so over 400 at the moment, I understand. And you got to feel for these patients. If you're a high-risk patient, you're given wearable devices to do your oximetry and observations. You get 3 video calls a day. If you're under 50, but you've got moderate symptoms or any comorbidity, you fall into that group. And the deterioration happens in about day 6 to 10. So those patients are often relatively well, but waiting to crash and burn. And it's quite a stereotyped deterioration. The day before they get really sick, they'll have some dizziness or syncope or postural hypertension, and then the respiratory symptoms start the next day. And that group of patients, 80% require admission, and nearly all of them if they're in an older age group. And it's sobering to think how many patients, now there's 2,500 active cases today, 10% of those are going to end up in hospital, and that sort of accumulates as the case numbers rise. So enough about COVID. I'll move on to the doctor's bag. So I'm going to go through most of the medications in roughly alphabetical order and tie them into a urgent or semi-emergent scenario in which they might be used. And I was just going to start off. I was asked whether, as a GP, when you've got someone with acute chest pain that could be a acute coronary syndrome, whether they should all be given aspirin. And I think the answers are a resounding yes. We know from big trials in the 1990s that just aspirin alone reduces mortality in myocardial infarction by about 25%. Being on anticoagulants isn't a contraindication to aspirin. If someone's already on regular aspirin, the extra dose doesn't help at all, but won't do any harm. And who knows how compliant that patient is. And it's rock solid in the ambulance protocols that everyone gets aspirin. So they're going to get it anyway. So you might as well give that early. Just to show you, in ED, if someone's got a ST elevation myocardial infarct, we'd give 300 of aspirin, 600 of clopidogrel or some ticagrelor, and a bolus of heparin. And the patients usually don't run into any bleeding problems. I would probably withhold the clopidogrel in your general practice. If there's a patient who's likely to have triple vessel disease, so maybe a 70-year-old diabetic smoker who may end up needing an urgent bypass, if they're on clopidogrel, that makes that operation a bit more problematic. But certainly give them aspirin as soon as you suspect the diagnosis. Now, oxygen, when I was at medical school and when I was a junior doctor, anybody having a myocardial infarct or having a stroke was given often 15 litres of oxygen, and we were super saturating the blood to minimise ischemia. So we know now that oxygen seems to do harm in both stroke and ST elevation myocardial infarction. There's a big study in 2015 called the AVOID trial, and there was another study published a couple of years later in the New England Journal of Medicine. So oxygen has gone from essential to a poison, basically, in states of ischemia, unless your oximetry falls below 93%. Okay. Now, a bit about out of alphabetical order, naloxone. So I see the doctor's bag has 5 400 microgram amps of naloxone. I've just pictured, I'm a big fan, as we'll come to, of intranasal medication administration, and naloxone also can be delivered quite well through a nasal atomizing device. So just a few things about naloxone. I guess when you're treating an opioid overdose, especially in the pre-hospital setting, it's a case of titrating the naloxone to the respiratory rate. Don't worry about their level of consciousness. And if they're breathing, I wouldn't give it at all. Giving naloxone risks of precipitating opiate withdrawal, probably worse combative behaviour, especially if the person's had a little bit of cerebral hypoxia, and maybe they're not a nice person to start with if it's illicit narcotics. You may induce pulmonary edema, rarely you may induce a cardiac arrhythmia. And we know naloxone's shorter duration of action than most opioids, and a lot shorter than the oral opioids. So you risk waking the patient up who goes away and then succumbs to their overdose. Interestingly, oral opiates often need huge amounts of naloxone to reverse their sedative effects and respiratory depression. So if someone's had a big overdose of buprenorphine, atorphine, or endone or targin, endone anyway, we're usually weighing with 2 milligrams up front and repeat that every 5 minutes up to 10 milligrams. In ED, in fact, we would usually just intubate the patient because you could use up the whole department's supply trying to keep that patient awake. So oral opiates, I'd be tempted to give all 5 ampules, but if the patient's breathing and not blue, I'd probably avoid it altogether. Okay. On the intranasal theme, intranasal fentanyl, I know it's not in the doctor's bag, is a wonderfully effective, rapidly acting analgesia. It starts working in probably as little as 5 minutes, maybe even less. And it's so effective in kids with long bone fractures. That's our initial go-to analgesia, and that settles them while we get some more definitive analgesia in the pipeline. The pediatric dose is 1.5 micrograms per kilogram, and that allows for a little bit of dead space in the end of the syringe. And as a single agent, it's really safe. You can repeat half that dose or even the whole dose if it doesn't do the trick. And like a lot of medications in pediatrics, as a single agent, they're very safe. It's only when you start adding a benzo or something else that you run the risk of respiratory depression. And morphine allergy in both adults and kids is not a contraindication because it's a different class of opiate. You can do this to adults, it's just a bit of a bigger volume. Okay, so next. So buccal midazolam for pediatric seizures. I mean, the recommendations are that to wait 5 minutes if the seizure spontaneously terminates. And it's thought there's this window period between 5 and 15 minutes when midazolam's highly effective at terminating a seizure. And then as time goes by, it becomes less effective. So certainly if a fitting child is brought into your surgery and it's been 5 minutes, jump in early with oral midazolam. The dose is 0.3 milligrams per kilogram. And respiratory compromise is almost unheard of in children, even with quite big doses, up to 0.45 or even 0.6 milligrams per kilogram. So buccal is often the preferred route, and even parents can do this at home, or intranasal route. They both have blood levels within minutes, and a bit like sublingual nitrates, you're bypassing the first pass metabolism in the liver, so you're getting a lot of your dose on board. I was asked how long should you observe for. So the peak sedation of buccal midazolam is at around 15 minutes. So if they're not too sedated at 15 minutes, they're not going to get worse. So if it's one of those recurrent fitters that doesn't really need to come to hospital, probably 30 minutes observation would be plenty. So picture up the top, so child's ideally on their side, can be syringed into the buccal mucosa on the dependent part of the mouth. The Royal Children's Hospital Melbourne has a lot of good protocols and guidelines, and it can be accessed by anyone. You can just Google it up. So if you go to the right-hand side of that graphic, so 0.3 milligrams per kilogram, buccal mucosa, still fitting. You can give another dose 5 minutes later, or you can give your Medazolam IM. So if you only want to remember one number, it's the buccal dose is twice the intramuscular dose. Okay. And so you can give it intranasally as well. Now I saw clonazepam drops in the doctor's bag, which is not a medication I'd actually ever heard of, and I was intrigued to see what that might be a first line indication for. I see it's 2.5 milligrams per in 10 mils per mil, and there's 10 mils, 0.1 milligram per drop. Interestingly, this is something I learned. It's considered potentially the go-to drug for behavioural control in autism and developmental delay, with the dosage as shown there of so under 10 years, 0.125 to 0.5 milligrams. Onset within 20 minutes to 60 minutes, so not super fast, but reasonably quick, with a good duration of action of about 6 to 12 hours, which is probably the amount of behavioural control that you'd be looking for. And I couldn't really think of any other really good indication for clonazepam drops. Okay. Antipsychotics. So the question was, I see there's 2 first-generation antipsychotics in the doctor's bag in chlorpromazine and haloperidol. So I was asked which would be preferred for behavioural control, and what would you use in the ED? And I think the answer is for neither of these drugs are very good for acute behavioural control, and certainly not very good if in the drug-affected or highly disruptive individual. Partly the slow onset. So for chlorpromazine IM, they talk about an onset of 30 to 60 minutes and 30 to 45 minutes for haloperidol, which is obviously quite a long time for a severely disturbed patient. Some of the geriatricians still use tiny doses of haloperidol in the elderly, of like 0.5 milligrams or 1 milligram. But if you compare that to droperidol, which is what we use in ED, it has very rapid action. It works in 5 to 10 minutes. So we would give 5 to 10 to 15 milligrams IMI. Now, the toxicologists recommend if the patient's very disturbed, just to give that in the lateral thigh and just give it straight through their genes. The risk of that causing an infection or planting some tissue, some material into the tissues to cause an abscess is incredibly remote. The risk of a needle stick injury to try to undress that patient or cut their clothes off is considerable. And the beauty of droperidol is mostly we get away with one dose. I'll put a few of the side effects there. I mean, it lengthens the QT interval. Sometimes these patients might be on other drugs, particularly methadone is a great prolonger of QT intervals. So theoretically, there's a chance of inducing a ventricular arrhythmia. So I hunted around, I found one huge meta-analysis of 16,000 patients treated with these antipsychotics for 1 death and 5 ventricular arrhythmias that were non-fatal. So it's probably a theoretical more than an actual complication. We know we can get extrapyramidal syndromes acutely with all of that, the phenothiazine class of drugs. You're also a bit more likely to fit. And I think for lots of reasons, looking at the doctor's bag, you can't go past some IM Medazolam, I think for urgent behavioural control and a very good safety profile. Now, I was also asked about refractory migraine and the benefits of sending, this is the genuine migraines, not the migraine in inverted commas, of sending those patients to ED when they failed first-line therapy. So I'm imagining first-line therapy is aspirin, something like metoclopramide and a triptan. I'll put anything IV. I think these are good patients to send to emergency because if you've exhausted what can be done readily in the general practice setting, we can often do lots for them. And things just work so well intravenously, some fluids and some IV Maxolon. I spoke with one of the neurologists who has a particular interest in headaches and migraine. who's a fan of giving some ketorolac, 30 milligrams IMI as a one-off dose, and has also had success with promethazine, so another phenothiazine, in a dose of 12.5 to 25. I'd probably sleep for a week if I had 25, but she's had some good success. But what we do in ED is we use chlorpromazine, and we give it as an intravenous infusion, so 12.5 milligrams in a litre, and we give that over 60 minutes, and we give a second dose if that doesn't work. It does cause some postural hypertension, especially if the patient's a bit volume deplete, if they've been vomiting or have poor oral intake. But a lot of the time that postural hypertension is asymptomatic, so it worries us more than it worries the patient. And sometimes it just is absolutely miraculous. Someone's had a headache for days and they're pale and vomiting and miserable. We tend to put these patients in short stay where it's a bit darker and quieter, and you go back and they're sitting in the chair next to the bed wondering if they can go home. So very happy to see refractory migraines, and neurologists are always happy to have a chat about refractory migraine as well. Now, I'm not sure if you use corticosteroids for migraine. Was listed years ago in various protocols as a fourth-line drug, that it may prevent recurrence, and people have had migraine for days and days. It may shorten the duration. Once again, talking to my neurologist friend, if she's had some of the really wicked migraine, and it's after several days it's finally settling, there may be an argument for giving a short course of either dexamethasone or prednisone, 25 to 50 a day, just for 3 days with no taper. Well, there's not a whole lot of evidence to support that, but if I'd had a terrible migraine for 3 days, I'd be sorely tempted to give that a try. Okay. Interestingly, this article came out a month ago, actually, that people with migraine generally have had increased frequency during the COVID era. A few have had less migraines, and it's, I say 10% have gone from episodic to chronic recurrent migraines. And the theory is that control of migraine, it's depends on sleep and diet and various behavioural things, and when we're all doing things differently during the COVID era, and maybe that's increased the rate of migraine. And I guess what we're looking at I've been surely during lockdowns there'll be more domestic violence and elder abuse and child abuse and heavy drinking. It's hard to quantify, but we're all very alert for these illnesses that might change with changes in people's behaviour. Okay, I'll just have a sip of water. So vitamin K, I see, is in the doctor's bag as well. Sometimes we have patients sent up looking for some oral vitamin K, but the IV vitamin K is perfectly good to give orally, and that's what we give. And I've printed out, I've just included there the warfarin over-warfarization protocol that we adhere to. So basically, if you're under 4.5, obviously there's not much to do. 4.5 to 10, if the INR is under 6, we'd almost never give vitamin K unless they're actually bleeding or super high risk. And if it's over 6, or there is a high bleeding risk, we give the dose there of 1 to 2 milligrams orally, or maybe 1 milligram intravenously. Vitamin K is such an effective reverser that if you give a big dose, it'll be weeks maybe before they can be effectively re-anticoagulated. And I guess the problem in general practice is you get the INR result maybe in the afternoon from a blood test done in the morning, and you don't know if it's still going up or going down. So I think these are also really high INRs, especially in the elderly. They're good patients to send to emergency because we can repeat the INR, we can bunk them down in short stay, and watch very carefully as it either runs down or we titrate our reversal. Okay. Now, croup. I thought I'd talk about a chance to talk about adrenaline and a chance to talk about croup at the same time. And I notice in the doctor's bag you've got 5 1 milligram ampules of adrenaline. So the dose required to effectively treat croup is quite high. So it's 0.5 milligrams per kilogram up to 5 milligrams. So a child over 10 kilograms, you should be giving 5 milligrams or the whole packet. And hopefully one dose will get you through until the ambulance arrives. I mean, a lot of treatment of croup is minimal handling and limiting examination and getting the child settled down and trying to improve their breathing patterns. So instead of this high resistance turbulent flow, that we get some nice smooth laminar flow. So what I try is take the mask off the nebulizer and waft the actual nebulizer under the child's mouth. And if you can get them to take a few breaths, I'm sure they start feeling better. And then they start taking bigger breaths, and then they're often happy to have the mask put on. If it's causing terrible agitation, then it's probably not worth doing. We would normally observe for 4 hours after giving some nebulized adrenaline. And if a child unwell enough to have a second dose, we virtually always admit. And I was asked about whether adrenaline has a role in upper airway obstruction. I can't remember if I've got a slide. Oh, I'll just do this slide first, actually. This is once again from the Royal Children's Hospital with some just a little table showing severity of croup. I guess it's all fairly common sense, but just a couple of things I note. The loudness of the stridor is not particularly helpful at telling you the degree of obstruction. And in fact, really quiet stridor can be more worrisome. And if you look in the severe column, persistent stridor at rest. So if it's soft stridor, if it's persistent, that's an indication of severe disease and a good reason to give a dose of nebulized adrenaline. Nebulized adrenaline shows very little toxicity in kids. It might make them a bit tachycardic, I'm sorry. But even with repeat doses, there's really very little in the way of complications. And just going back to upper airway obstruction, I guess inflammatory upper airway obstruction, it's different to croup. You know, if we can just shrink those vocal cord or upper airway edema a little, we'll turn that turbulent flow into laminar flow. Usually not so in other causes of inflammatory upper airway obstruction, but it may buy a bit of time and it may make intubation easier if it comes to that. So if there's an upper airway obstruction with stridor, child or adult, it's probably worth nebulized adrenaline. And just a reminder that not everything that produces stridor is necessarily croup. So there's these little magnets seem to be very popular for kids to swallow. So there's 2 magnets sitting there in the region of the epiglottis, causing that child to have stridor. This child's got an opened earring actually in its larynx. Very small child with very loud stridor. That was quite a distressing patient to look after, but everything ended well with an emergency trip to theatre. The foreign body story, I might say, wasn't really evident in this child, but it just didn't seem like normal croup. So we did an X-ray. Most time, obviously in croup, there's not a good place for X-ray, and we certainly don't want to be sending that patient around the corner up the corridor to radiology. But in selected cases, or for foreign body strongly suspected, some simple radiology is worth doing. There's just a lateral view. Might be a bit hard to appreciate on the screen, but a very big esophageal foreign body can impact on the airway and cause stridor. This X-ray shows actually a peach stone. You can sort of see the pattern of the peach stone lobbed in the esophagus and pressing forward on the airway, causing this child to come in with drooling and stridor. Okay, so what about adrenaline for anaphylaxis? Well, probably all know the dose. It's 0.01 milligrams per kilogram for children and 0.5 milligrams for adults, delivered by deep IM injection in the lateral thigh. And I find if I give adrenaline, I would, adrenaline's a vasoconstrictor, which will limit to some extent its absorption. So after injection, I'd advocate really massaging that spot and spreading that adrenaline around and getting it to work as quickly as possible. You can repeat it up to every 5 minutes. And I say, if there's any stridor or voice changes, you can try some nebulized adrenaline as well. Voice changes particularly tell you that there's laryngeal edema. And even if the patient looks very well, laryngeal edema is quite a big red flag to progression to airway obstruction. So I would always give adrenaline if in anaphylaxis or severe allergy, if there's stridor or voice changes. If they happen to be wheezy, salbutamol is still recommended. And one thing we do these days is for foodborne allergens, there's a risk that some of that antigen might be stuck between the teeth, and the patient will have their initial reaction, then get better, and then when you let them eat and drink, they'll wash some food particles into their mouth and down their GIT, and provoke a second round of anaphylaxis. So they should always have a really good rinse and gargle as soon as they're well enough to tolerate that. Now, there's steroids in the doctor's bag. We don't use steroids acutely for anaphylaxis. They take 4 hours to work anyway, so they're not going to help particularly in the initial episode. There's this thought that maybe they prevent a biphasic anaphylactic reaction where the patient gets better and then a few hours later gets worse. And it used to be said that these biphasic reactions were common with ingested antigens. It made sense that they were maybe still being absorbed from the GIT. We know now that the biphasic reactions are much more common with bites and stings, like European wasps particularly, and not so common for food allergens. But we always, if we've given adrenaline, we always observe for 4 hours. And most of the time we're actually able to discharge those patients. Certainly old protocols, we've to use promethazine. 12.5 IVI was very popular and always worked for me. But it's thought that any drug that's going to produce somnolence and drowsiness in a patient who has a potential for airway obstruction is better avoided. So promethazine is now thought to be contraindicated in anaphylaxis, although we will give an early dose of a non-sedating antihistamine. Okay, anaphylaxis is quite fun to treat because it's simple, and you can see the relief on the patient's face within minutes as the adrenaline kicks in. And I saw glucagons in the doctor's bag as well. And there was a query that if I've got anaphylaxis in my beta-blocked patient and the adrenaline's not seeming to work, is there a role to going to some IM glucagon? The theory is that the glucagon, it doesn't need adrenergic receptors, so it doesn't bypasses alpha and beta receptors, but it activates adenylyl cyclase, increases cyclic AMP, and has much the same as adrenaline, or could theoretically have a similar effect to adrenaline in the beta-blocked patient. So it sounds good in theory. I guess the other things glucagon's used for, we know obviously we treat hypoglycemia because it releases liver glycogen stores. Unless you've got severe liver disease or truly starved, it's not going to do that. There's a possible role for esophageal food bolus impaction, which I'll speak about in a minute, and then beta blocker toxicity and anaphylaxis in beta blocked patients. So just to go through those, to have an adrenaline-like effect in beta block patients, you need really big doses, and probably at least 10 to have an effect. I noticed the doctor's bag, I think, only has 1, or 0.3 milligrams per kilogram in children. And it sort of works in 20 minutes or it does nothing. Because it causes paresis of your gastrointestinal system, you'll have pooling of secretions in your esophagus and pooling of contents in your stomach, and the rate of emesis is quite high. And even with a 10 or even 20 milligram dose, the benefit is thought to be very small. So I wouldn't bother at all with giving you your 1 milligram of glucagon in that setting. And just for your interest, the modern approach is to give ultra high dose insulin, which, believe it or not, could be hundreds of units of insulin, and then enough sugar to stop them from becoming hypoglycemic. Even then, the effect is not proven, but that's our current approach to beta blocker overdose or anaphylaxis in the beta blocked patient that doesn't respond. And here we go. So I'm not sure if you've used glucagon for esophageal foreign bodies. It was very popular for particularly a food bolus. I thought it'd relax your lower esophageal sphincter, and anecdotally it did seem to work back in the day. So looking around, I found this pretty big systematic review. It looked at 5 studies, really big number of patients, so 1,185 patients. They looked at using glucagon or doing nothing. And as you can see from the percentages there, the glucagon group did no better at all at the control group, but they vomited more often. So I think we can confidently draw a line through glucagon for esophageal foreign bodies. What we do still use in emergency is a trial of carbonated beverages to help shift foreign bodies. The evidence is minimal. There's some small studies that show it seems to work, and it won't do any harm. So some Diet Coke or whatever it is worth a try. And it's thought that the carbon dioxide, I think, then relaxes the lower esophageal sphincter and helps the food bolus pass. And I found it's not available in Australia yet, unfortunately, but there's, just to carry on the nasal administration theme, there's a glucagon nasal spray around in other countries, and that would be a good addition to the doctor's bag, I think, when it's available. Okay, have another sip of water. Let's just deal with a particular condition, which can masquerade as anaphylaxis, and can lead to patients being branded as having a seafood allergy. So I'll just illustrate this with a case I saw a few years ago. It was a very healthy couple in their 60s, and they were having dinner at a local club. They were eating mackerel steaks, which tasted just fine. And about 20 minutes into the meal, almost within minutes of each other, terrible nausea and vomiting and itch and headache and dizziness and loose motions and palpitations and flushing, and an ambulance was called, brought up to emergency. And sure enough, on examination, they're tachycardic, there's a bit of mild hypertension. The erythematous rash is only of the head, neck, and upper torso, and there's quite a bit of bronchospasm as well. And what these patients have, I don't know if it's well known, is something called Scombroid Poisoning. And it occurs after eating fish, gets its name from the Scombroidae family of fish. And these are those oily fish, the tuna and the mackerel and sardine, swordfish as well. And also happens in Swiss cheese. And just earlier this year, I saw 2 individuals who came in with this condition after having Swiss cheese. Obviously, if you get 2 people with the same illness, it's not going to be an allergy. And that's sort of a bit of a too dramatic a presentation to be attributed to food poisoning. So what happens is that there's histidine in those oily fish, and certain bacteria turn that into histamine. So you've got this histamine-laden fish, and certainly acute blood samples taken in Scombroid poisoning show elevated histamine levels. I think I've got one more slide there. So the histamine is not broken down by refrigeration, freezing, or cooking. So this bacterial growth could have happened at any point of the supply chain. So you can't necessarily blame the poor old club that served the fish. And once the histamine's in the fish, when it's eaten down the track, it's going to cause that reaction. They say the onset's 15 to 60 minutes. You can almost set your watch by it. It's about 15 to 20 minutes after eating fish that it happens. And one Melbourne Cup day a few years ago, there were 3 tipsy 40-year-olds having a nice time who had the swordfish steaks, and all 3 of them came in by ambulance, beetroot red face, tachycardic, vomiting their heart and lungs out. But they get better very quickly. The treatment is antihistamines, obviously, because it's a histamine toxicity, and some supportive care. But the big thing is to recognise this condition if you can, and avoid branding that patient as seafood allergy and avoiding seafood for the rest of their life. We might, at the end of the talk, maybe if there's some questions, I'd be happy to answer them. So I'll just check the time there. How are we doing? So I also asked, is it worth having a Goodell's Airway in the doctor's bag? So there's 9 sizes of Goodell's Airway, and as per the picture on the left, it stops the tongue lolling back into the posterior pharynx. So it's good at maintaining an airway. I guess you need the right size. So the sizing is per the other picture there, from the central incisors to the angle of the mandible. So you've got a nice toothy landmark and a nice bony landmark. So sizing is quite an easy thing to do. But you'd have to carry a range of them, probably at least a 5, a 4, and a 3 for most adult situations. Let me just remind me what my next slide is. And obviously, if it's not long enough, it's not going to do the job. And if it's too long, it's going to make you vomit, aspirate. Really long one could even tickle up your larynx and cause laryngospasm. If the patient happens to be post-ictal, if they fit again, there's a risk of them breaking their teeth. So I would go for just, I think, simple airway manoeuvres and posturing to optimize the airway would probably be adequate in most situations. So I don't think I'd advocate for a Goodell's airway. If you do want to carry an airway adjunct, I'd carry a nasopharyngeal airway. They're quite cheap, they're single use, they're soft, it comes in 4 sizes, which will cover everything from bigger children to large adults. You do need some lubricant to insert it. And I guess we're in an era where it seems like every second older person is on an anticoagulant, often a NOAC, and it can cause really bad epistaxis. So I'd be very cautious in an anticoagulated patient. But otherwise, they're well tolerated, don't cause vomiting, and the patient just pulls it out when they wake up enough. So that would be my my airway adjunct if I was going to carry one. Okay, yeah. I'm going pretty quickly here because we can get through as much as we can, and then we can talk about it in at question time. So the other question was, when I'm seeing SVT in general practice, I've either proven it on an ECG or the patient is known to have recurrent SVT. Do Vega maneuvers work, and are they worth trying? So Valsalva's the classic vagal maneuver. I'm sure we were all taught carotid sinus massage back in the day, eyeball pressure, and especially in kids, but in adults too, ice and cold water on the face initiates a diving reflex and can terminate SVT, sometimes very effectively in children, as a matter of fact. So eyeball pressure and carotid sinus massage have gone out of fashion for a few reasons, but Valsalva maneuvers are still very much worth trying. And I'm not sure if you've heard of this. There's something called the REVERT study, which looked at a modified Valsalva maneuver, which is what we do in emergency. So it involves getting the patient in a semi-recumbent position, and then they do a Valsalva maneuver, and it's got to be 15 seconds. And it's hard to encourage patients to expire against a closed glottis for that length of time. But anyway, after 15 seconds, you plop the patient down flat, you lift the legs up for 15 seconds, and that hugely increases the effectiveness of a Valsalva maneuver. So in the REVERT trial, they had 428 patients randomly allocated to one or other treatment. And with this modified maneuver, 43% of patients achieved sinus rhythm, compared to 17% for the standard Valsalva. And I'd say we probably would revert 50% of SVTs without drugs, actually, in the emergency department. Question is, what's a good Valsalva maneuver that's easy to explain to the patient, because they may not understand expiring against a closed glottis. And what we do is, and most places do, is if we use the old 10 ml syringe trick. So it's thought an effective Valsalva in SVT, you need about 40 millimeters of mercury of positive pressure, which is quite a lot. And ideally to hold that for 15 seconds, which is a long time. So if you give your average adult a 10 ml syringe and say try and blow the plunger out, it's actually really hard to do. And if once they start moving the plunger, they'll probably blow for a full 15 seconds without blowing it out. So that's a really easy Valsalva maneuver, and you can give the patient the syringe to try again at home. They should lie down. There can be a pause when SVT reverts, but otherwise it's certainly something I'd be trying in the surgery if you're happy with the diagnosis. And I mean, this is my favourite Valsalva maneuver, as if you push forcefully against the patient's abdominal wall and ask them to push back. And the only way they can push back is to expire against a closed glottis. And if they're young and male, they'll take this very seriously. You need lots of verbal encouragement for them to push hard and hold it for 15 minutes. But I have really good success with that. I mean, we do have adenosine, which is highly effective at reverting SVT, but it causes terrible dysphoria to the point where some patients just refuse to ever have it a second time. So I'd always try some Valsalva maneuvers. And yeah, the syringe or pressing on the abdomen are really simple things to do with high success rates. Okay. A few other things. So SVTs are not generally electrolyte-mediated arrhythmias, so it's been shown that biochemistry is not required. Even a fit young person who's had some sustained episode of rapid SVT, they're very likely to get a troponin blip. And if you get a raised troponin, then I guess you're committed to do a second one. Unlike acute coronary syndrome, where the troponin may stay elevated for a sort of week or 10 days, these short leakages with arrhythmias, the troponin normalizes very quickly. So the patient can generally be discharged, which just means they might need 2 or even 3 troponins. So we would generally, in ED, avoid a troponin in the context of SVT, unless there's other ECG changes or they had terrible chest pain. So just the other point, it's well known that SVT is allegedly more common in infants and children than adults, but they tend to grow out of it up to age 2, and then after age 2 it tends to be recurrent. And the figures, 1 in 250 to 1 in 1,000 children have an episode of SVT by age 2, and I'm sure we don't diagnose them all that often. The signs include pallor, so often they just get terrible pallor when they're in SVT. I've seen a number of feeding problems, in inverted commas, that were SVT, tachypnea, and more recently I've seen a couple of children with terrible tantrums. One, the ambulance got called to the daycare centre because his tantrum was just so uncontrollable, and I could see the carotid pulsing around at 300 in the neck, and we got some leads on it, and they had SVT. So I just wonder how many of these, how many times I've missed paroxysmal tantrums over the years. So yeah, if you could just count out a pulse at least, if a child's got any of those symptoms. And as I mentioned, the ice water and the ice pack actually works really well in kids, and it sometimes works in adults as well. I had a lady the other day who had SVT out at a nightclub, and she refused adenosine, and she was needle phobic and demanded a tub of ice water, which she plunged her head in repeatedly, and with mascara running down her face, and it was quite a funny sight. Okay, let's check my timing again. There we go, good. So pneumothorax. Now, when we did this talk, I think it was 2017, there was a big multi-centre trial going on, including at St George Hospital, of managing pneumothoraces with a watch and wait approach rather than intervention. So that X-ray there belongs to a tallish 35-year-old guy who's very well. He's been a bit short of breath, a bit of chest pain for a few days, and he's got this really large pneumothorax. So his lungs just this little squashed up bit at the left base. So there was a time when that man would have got a large bore chest tube, and then in recent decades a fine bore chest tube. But our study has finally made it into print. It enrolled a huge number of patients that for various reasons were excluded for problematic follow-up. But basically 85% of patients with moderate to large pneumothoraces, so 32% I think was the inclusion, did perfectly well without intervention. And what's the rationale for this? Well, if you a spontaneous pneumothorax is treated with a chest drain, a quarter of all patients will have another pneumothorax on that side within 12 months. And if you look way back 50 years ago, there were some studies that showed recurrence was very rare if you just left it alone and let the lung fix itself. And the thought is if there's a pleural bleb or a tear in the parietal surface, that having the lung collapse down and then have a chance to heal and then gently re-inflate is probably going to have a better outcome. And if you look at the average length of stay in patients that actually get a chest drain, it's huge. It's 3.4 days, and half the patients get complications. So if you can get away with that intervention, that's wonderful. So this study has shown effectiveness if you exclude patients who had a previous pneumothorax, if they've got bilateral pneumothorax or it's secondary to some trauma or illness, or they're unstable, or they're over 50, or if their chest pain or dyspnea is interfering with their ADLs. So what we normally do is we'd re-X-ray the patient at 4 hours, and if the pneumothorax getting bigger or their obs are going off, then we would probably intervene. But amazingly, radiological tension is not an exclusion. So if a patient can walk up and down the corridor and they're not too bad, although it gives you a funny feeling, they're sent home with a radiological tension on their X-ray, and they mostly do very well. I think I've got a slide or not. But patients typically present with pneumothoraces usually in the second or third day. So if someone came to your general practice and they'd had some symptoms for maybe 2 or 3 days, so they're very stable, and you've got an X-ray that shows a pneumothorax, there's probably no reason to do the 4-hour X-ray. They can have another X-ray the next day, and then in this study, X-rayed fortnightly until resolution, which tends to take about 6 weeks. But it's a lot better than having intervention. One of my registrars last month popped a pneumothorax for the first time during a shift, and is a very academic fellow who was aware of this paper, and it was a 40% pneumothorax, and he had his X-ray and then went back to work and was happy to finish his shift. So tension pneumothorax, and what's the risk of a spontaneous pneumothorax turning into a tension pneumothorax? And basically, it almost never happens. So patients, mostly by the time they come to medical attention, they've declared their stability already. And it's the clinical features of tension pneumothorax that we really worry about. And once again, 100% pneumothorax, they mostly do very well with conservative management, which I know that sounds hard to believe. Okay, now we're very keen on ultrasound these days in emergency, and we've got lovely little bedside machines that we can wheel around, and lung ultrasound is becoming more and more popular. So if you plonk a linear probe on the uppermost part of the chest wall between 2 ribs, you can actually see the 2 pleural surfaces sliding on one another. So it's really, really sensitive for ruling out a pneumothorax. If there's any air at all, you don't see the visceral pleura at all. So you can't tell the size, but it's very, very good for excluding pneumothorax. The only downside is it takes the tiniest smidgen of air to lose that pleural sliding, and we'll be finding pneumothoraces that otherwise we wouldn't have known about, that are probably clinically insignificant. But you might sometimes see that in the discharge summary, so that's what we're talking about. So electrical injury. So I'm not sure how many electrical injuries you see in general practice, but I'm guessing they're mostly household voltage shocks, and I imagine the patient probably presents some way down the track from their acute injury. And like most medicine, the answer is usually in the history. To find out the voltage, which certainly tradesmen can always tell you the voltage, and then some way of sort of working out the current and the resistance and the duration and the pathway of that electric shock, and whether it was AC or DC. So believe it or not, in terms of electric shock, anything less than 1,000 volts is low voltage. So household power is regarded as low voltage. And at that level, internal burn injuries are very unlikely. You won't get damage to solid organs and blood vessels and burn out nerves. If there's a bad outcome, it's AC current's going to cause initial VF. And if you don't get VF initially, cardiac arrhythmias subsequently are incredibly uncommon. Should we do a troponin? Well, the utility is unclear, and I would probably not. But let's say if we're trying to work out the amount of current that patient's received, I mean, the really big thing is wet skin. So someone with bare feet on a wet floor, wet skin's got about 100th the resistance of dry skin, and skin that's sort of burnt through to the juicy lower layers has even lower resistance than that, whereas charred skin has very high resistance. So find out what the patient was standing on, what shoes they had, if it was wet or dry. I think the last death I saw was someone standing in ankle deep water, drilling a hole in a wall of a laundry, and he with a metal drill pressed against his chest, and he drilled into a 240 volt wire. So obviously great conduction and terrible current path. So just to look at terms of current, I say 1 to 4 milliamps is where you start to feel a little bit of a tingle. And then you get some tetany maybe at 16 to 20 milliamps. And to get VF, you need 50 to 100. So it's 30 or 40 fold the level at which you can first feel a slightly unpleasant sensation. So what sort of injuries do you get? Well, if you don't get VF, you may well get burns. So flash burns, where two wires flash together, tend to be quite superficial. But arc burns, by contrast, tend to be really bad, where a current arcs across from a high or low voltage source. Causes often deeper injury, much deeper than you think. And exit wounds are also a form of arc injury, and they're always worse than they look. So the picture there shows some exit burns in someone's feet. If they look bad today, they'll probably look worse tomorrow. The other sort of burns is contact burn at the entry site. Sometimes, obviously, if clothing catches fire. And it's easy to forget about traumatic injuries. If someone's been blown across a room or knocked off a ladder, they might have all their focus on the burns of the shock, and we might forget to check for trauma. So who do we need to see and who do we need to admit? Well, we admit people have had unconsciousness just because it's hard to rule out that they haven't had a cardiac arrhythmia and any new ECG abnormality. And there's no ECG abnormality particularly specific for electric shock. Just be conduction abnormalities, new bundle branch blocks, vague STT changes, or prolonged QT. And these things nearly always resolve, but we take a line of caution and usually admit those patients. Fetuses anywhere past halfway through the pregnancy are very sensitive to electric shocks. So any advancedly pregnant female electric shock should come to hospital and should have some monitoring and a CTG. Now, we admit people who've got known bad hearts and a terrible current path. So someone was holding a tap and got electric shock to their other hand, so the current's gone straight across their heart. They would be admitted for overnight monitoring. That said, delayed arrhythmias are incredibly uncommon, especially if the first ECG is normal. Those more concerning patients, we tend to observe them for 4 hours in EDs and then send them home. It seems a sensible thing to do. There's no science to support that. Just to finish on, the electrical burns are always worse than they look. And electrical burns to hands, we refer them all to the hand hospital for review. Good. Okay, so it's nice to talk about lightning. So I've got that nice pretty picture there to start with. So lightning is very different to the AC current we see from electric shocks. So it's a DC current, and it's incredibly high voltage, 2, 3, 4, 5 million volts, and of a very short duration, maybe 1 millisecond. And most of the current does what we call flashing over the object that it's hit. So it's not usually all conducted to the ground. And if it wasn't, then no one would really survive a lightning strike. The mechanisms of injury, so there's direct strike. I'll show you a picture in a moment. There's something called side splash or flash, where it hits an object and jumps across to a person. There's some contact with something metal which is conducted along, and there's something called ground current as well. We also see some blunt trauma from muscle contraction and blast. And there's lots of, as I'll do a slide off shortly, many systems that can be injured by lightning. The cause of death, I mean, when we cardiovert people electively in emergency, we're delivering a DC current, we're producing asystole for a short period of time, and the heart resumes a spontaneous rhythm. And it's no different in lightning. It's just lightning also paralyzes your respiratory center. So you've got brief asystole and apnea as well. And as I'll come to, this is one of those few instances where in the middle of nowhere, a bit of basic life support can save a life. So pictures, so there's direct strike, which is often fatal. Contact, back in the days of landlines, I think I read somewhere, I think in Australia, there's 80 people a year got electric shocks using their landlines during a thunderstorm. Not an issue now with mostly mobile phones. So side flash, where it hits the tree and jumps across to the person. And then this ground current, which I'll show you another picture of as well, where the lightning hits the ground and then it spreads out in a radial fashion. And it can go up one leg through your body and down another leg. there's something called an upward streamer. When lightning comes down, there's another lightning bolt that goes up from the ground. So that's what an upward streamer is. But I guess ground current's a really interesting one. So picture there's lightning striking a tree. It's spreading out radially through the ground. It'll go up one leg and down the other, which if you're a human, you'll probably be fine. If you're a long-bodied quadruped, you could be in a world of trouble. So if you're near a tree, if you have to be near a tree, face the tree and put your feet close together. Cows don't know that, and there's instances where numbers of cows had died following a lightning strike. Side splash. So I can't remember where I got this picture from, but so here you've got a pole that's going to attract any lightning in the vicinity, and then next to the pole you've got this metal cage, and then you've got a metal seat in the metal cage. So if you're cowering in there during a thunderstorm, that's just a recipe for a side splash injury. The famous Lee Trevino, with one iron's a notoriously difficult golf club to use. He said if you're in a storm, run around the fairway holding a one iron, because even God can't hit a one iron. And I might just go through this really quickly, but just basically a high voltage, that would be something like 115,000 volts that we see in those high tension wires, versus lightning. It's a lower voltage, but usually more prolonged exposure. The lightning tends to flash over you, whereas the high voltages cause deep internal injury to nerves and vessels. One gives you asystole, the other atrial fibrillation. And lightning injuries rarely need things like fasciotomies. And I saw a guy who climbed up one of those towers and touched 115,000 volt wire, managed to blow both of his shoes off, laced up, and still survived. Just a few, I'll go through this really quickly. There's this, I've seen a case of this where there's paralysis of limbs, particularly your legs, where they're pale and pulseless, and sort of lightning induces this really intense vasospasm. There's these things called Lichtenberg flowers, where the lightning runs along your sweat lines, causing those superficial burns. Just other injuries include shoulder dislocation, usually a posterior dislocation. If the muscles at the front and back of the shoulder contract at once, the back of the shoulder usually wins. And tympanic membrane rupture. There's just some other lovely flowers. And just a few delayed effects: cataracts, retinal detachment, vestibular dysfunction, and sensory neural deafness. I saw a 38-year-old gentleman a few years ago with a lightning strike, and I bumped him down the shop 6 months later, and he actually had a hearing aid and was walking with a stick. So yeah, lots of delayed injuries can happen. So pre-hospital management, if you came across a group of, say, 5 people and one's pulseless, apneic with fixed dilated pupils, you normally consider that patient as deceased and turn your attention to the other victims. But if someone's moaning and groaning, showing any sign of life post-lightning strike, they're going to survive. And simple CPR, the myocardium will recover, and you can save a life. Jellyfish stings, so blue bottle pictured there. The old vinegar versus heat versus cold. So as far as I could find, the vinegar story came from, it produces the discharge of nemesis from these really nasty jellyfish like box jellyfish and irukandji. So sprinkling vinegar on can be potentially life-saving. Doesn't do much for pain. And the advice is, if you've got a severely unwell patient post unknown jellyfish, you probably should give vinegar, but I wouldn't think so in our climate. Salt water would be the next best thing, as fresh water makes the nemesis discharge. But for non-serious stings, in our temperate climates in the Indo-Pacific, they're almost always heat labile marine toxins. So some warm water for 20 minutes will relieve pain and denature the toxins. And oddly enough, the advice then is a cold pack if no warm water is available. Okay, just a couple of really quick things. Just to finish, I'll just whiz through snake bite. So most snake bites don't cause envenomation. And, some of the biggest series in Australia, and only about 9 or 10% of bites actually result in envenoming. Most victims are male, most victims are young, quite a few victims are intoxicated, and some have all 3 of those things and are also trying to catch the snake. And depending on the species of snake, it's neurotoxic, hemolytic, procoagulant or myotoxic effects. Most snake venoms have very rapid onset. So in that one of those big series where 9% of people were envenomated, at the time of medical presentation, 3/4 already had their clinical features, and virtually all in 6 hours. And likewise for the laboratory abnormalities, the coagulation profile and the CPK. So these places see lots of snakes. We'll discharge patients often at 6 hours. We see very few snake bites and have a very conservative approach. The good old pressure immobilization. So all snake bites, including sea snakes, funnel webs, blue ringed octopus, cone shell. Not much good for spider bites, make redback pain worse, and not recommended for those other things shown there. And I guess the pressure's the easy bit. The immobilization is really important too. There've been studies with venom analogues where you get one person to walk and one person to lie down, and the rate of the venom getting to the systemic circulation is 58 minutes if you're immobilized and 10 if you're walking. And once the pressure immobilization is in place, it needs to stay in place because the venom doesn't break down, and we can remove that in some sort of critical care environment with our anti-venom at the bedside. The preferred is a 15 centimetre elasticized bandage ideally, and you do one circumferential application at the actual bite site. It should be so tight you can hardly get a finger under the bandage. And then a second bandage. It's often best put over clothing if it's still there, from fingers or toes, and you go as proximally as you possibly can. Distal to proximal is probably better tolerated, but maybe less efficacious. If you're just doing a single bandage, the Australian Resuscitation Council advises distal to proximal. Splint the joint above and below, and if there's another site, not on a limb, just firm pressure. I guess brown snake is the one that we probably see the most because they're common in urban environments and they're aggressive. And their bites can be absolutely painless, often hard to see. And because they cause coagulopathy, patients might be asymptomatic until they get a complication. And pretty incredible toxin. It can you can have no fibrin left and an INR of infinity, and a clotting time of infinity after envenomation. There's a syndrome of early collapse cardiac arrest, and so that's little microthrombi whizzing down the coronary arteries and causing distal ischemia. And probably won't dwell on redbacks, but I guess redbacks, no one's died since 1957. We've got so it's rarely an emergency. Remember that the pain might be local, it might be regional, it can be very atypical. We sometimes see lymphangitis, sometimes see painful lymphadenopathy, sweating and piloerection. But occasionally with redback, the diagnosis can be a bit obscure. The pain symptoms, it can be the bitten limb, both limbs on that side, contralateral limb, face and chest. So, any really weird pain syndrome you can't explain, have a think about whether redback spider could be responsible. And I'll just, a couple of other things. So the antigen is prepared from horse serum, but major reactions are quite uncommon. It's usually given intramuscularly, but we would give it intravenously. Efficacy has recently been challenged. There's a big study by Jeff Isbister in Newcastle looking at time to pain relief and felt there was no difference. But in my experience, the systemic symptoms respond very well. And I would still advocate giving it in an unwell patient. Now the time is 10:02, so I might stop there and invite questions.
Right. Thank you, Peter. That was a really excellent talk as always. We have one interesting question here. He also thanks you for your awesome talk. It says that we use clonazepam drops a lot in palliative care patients for seizure management secondary to brain mets. It's very easy for their relative to give it home, which I didn't know.
Oh, that's very useful. Yeah.
That's very interesting. The other thing is Medazolam for adults. Do we give half or one sort of squirts, the lampules for adults who have prolonged seizures? I know you said the dose for children for Medazolam.
Yep. So we normally give 2.5 or 5, but if it's buccal, I'd give 5.
Yeah. Yeah. Also, another one is, how quickly do you see the benefit of adrenaline in anaphylaxis? Is it 5 seconds, 30 seconds, or 1 to 2 minutes? Because in Hollywood, it's always instantaneous.
Yes. Well, intramuscularly, it's within 2 minutes, I'd say. The patient starts to feel wonderful, and often a full effect in 5 minutes. So it's really, really quick. And I'll say if you inject it and then massage the injection site vigorously, it seems to work a lot quicker. So it's a rewarding condition to treat, actually. It's easy for me to say because I'm in a resuscitation room as well, I guess. But yes, I'm sure still rewarding in general practice.
No, I know GPs who it's happened to, and they've sort of got an EpiPen, and suddenly it's just they're totally, come around and survived and were dramatically sort of better. But yeah, it's.
I mean, we see a lot of patients that have EpiPens and they've been instructed, but they don't use it on the day. I'm not sure if you see that there's the placebo EpiPens to practice with, and because if the patient won't inject the placebo in the surgery when they're well, they're probably not going to do the adrenaline when they're feeling really unwell. And we see people injected into fingers and all various mishaps as well sometimes. So, and it's quite a digit-threatening emergency actually if it gets injected into a finger.
And with some CPR courses, they've said, look, normally you tell the parents to get 2 EpiPens, 1 at home, and 1 at the preschool. But they've sort of said, no, you should always have 2 with you because you always might need to use that second dose.
Yeah, I guess in metropolitan Sydney, you normally get an ambulance before you needed the second dose. But yeah, I would have EpiPens everywhere, and 1 at grandma's and 1 in the handbag. And yeah, because just fate would have it the one day you wear the EpiPen, isn't it? When they'll have the anaphylaxis.
Someone's asked, just where is ice applied to terminate SVT? Do you have to sort of use the ice water on your face? Can you use an ice pack on your face or anywhere else?
It's a good ice water ice pack. So it's sort of be the primitive diving reflex that slows the heartbeat when we dive underwater, and it seems to be very particular to the face. So either a pack of a slurry of ice and water applied to the face, or you can dunk the face in ice and water. And kids have the strongest diving reflex, but it also works for adults.
I think I mentioned to you that I did see a paper of children with SVT and they held them upside down, and that was very effective. Yeah,
because that's the modified SVT as well, that you put a whole lot of venous return by so you've got the positive intrathoracic pressure holding up venous return, and then you put their feet up in the air and there's this massive venous return to the heart, and it seems to terminate the arrhythmia. And I guess that's the same holding someone upside down by the feet.
Much harder to do on adults.
Yeah, very inelegant as well.
Yeah. Any other questions? I think you've really sort of astounded everybody and sort of covered quite a lot of stuff.
Yeah. I hope I didn't talk too fast, but I thought I'd cover as much ground as possible.
That was really fascinating. I don't think we'll be going outside if there's a storm anymore. That's one thing. But no, that was great. So look, I'd like to really thank you, Dr. Grant. That was just a fantastic and really interesting talk. Someone's just said something. If anaphylaxis after an immunisation occurs, if you give adrenaline, won't the stimulus still remain? It's a good question.
It still responds really well, actually. So I'm not sure of the physiology, but yeah, it responds well. I'm not sure if you get a biphasic response to immunisations, but yeah.
You might have to send them into ED just in case you do, sort of thing.
Oh, for sure. Yeah, no, for sure. Yeah. I think it's the biphasic reactions I've seen most are European WASPs, where the patient's sort of 2.5 hours down the track and suddenly they get their symptoms back.
That's a really good question. Someone's also wants another question from me, sorry. Seems that standard practice at nursing homes to send residents to the ED every time they have an unwitnessed fall and they're on anticoagulants. No matter what their condition, they get a brain CT review. What's your thoughts on that practice and sending them into that?
Yeah, well, it's a very high expectation on the part of the nursing home staff that will do that. And if they don't send them in, often the next shift does, because they've got a cognitively impaired patient with a cut on their head, and they don't know if it's traumatic or if it's their baseline. It's quite a single CT that's normal. The chance of having a subsequent bleed I had another slide I didn't quite get to, is very low. What we're doing now with telemedicine, one of the emergency physician telemedicine services is that they examine the patient via telemedicine and give some strict instructions when the patient should come to ED. If they've had a significant head knock and anticoagulation, they basically need a CT.
Yeah, and a lot of them on NOACs at the moment too, as you mentioned.
Yeah, and you get surprises, or they get a very slowly growing subdural, and they get treated for sepsis or some other condition, and all the time it's a subdural. So given that a CT acutely has a high sensitivity of ruling out subsequent subdural, it's worth doing.
Okay, well, it's getting close to the time, so if there's no more questions, look, thank you, Dr. Grant. That was a really fascinating talk.
I'll just tell you one quick snakebite story. Just
yeah, sure, please do.
A lady down in Canberra worked on a puppy farm, and a black snake was chasing one of the puppies, and she was trying to swish it away, and she got this really innocuous little bite on her thumb. Did a pressure immobilization to her arm. We did the blood tests and all the usual things, got the anti-venom out, took the bandage off, and half an hour later she said she felt terrible. And then she developed an ocular palsy and got really sick. So the nature of the bite doesn't tell you much about how much venom might have been injected, and an innocuous little bite can be quite serious, and a seemingly deep bite can be non-envenoming.
Yeah, there's a few snakes in the Shire, particularly Grays Point. There's
Sutherland Hospital has a better supply of antivenines than us because of their proximity to the national park and bushland. So there's no value in diverting those patients to us.